benzodiazepines, almost anything that's been available, and almost always associated with alcohol. We find that the problems are far more complex than they were when we had a single drug problem. I think the other type of patient that we see far too frequently is a midsummer patient who's been given a mixed drink in the park and comes in comatose, the surprise overdose. But with our ready availability of numbers of patients, we've begun to reach out and find these solutions quite readily at this stage.
So we really ought to consider drug overdose in almost any patient that has altered consciousness. We find this no longer just in the ghetto youth who may have in the past abused heroin, but we now find it in all socioeconomic groups and ages. And narcotics play a prominent role in the whole spectrum of drug abuse.
Will you please get Narcan 0.4 milligram for me?
There are two very important reasons to consider narcotics specially. First of all, they're ubiquitous. There are literally hundreds of drugs that interact with the receptors in the brain that have a specific binding site for the opiate alkaloids such as morphine. And we will group all of these together and just call them narcotics. But they're not just things like heroin, but as you've heard, Darvan, Lomotil, Talwin, and a myriad of things that find their way into your medicine chest. And the second reason for considering narcotics specifically is that these drugs have an antidote which is highly specific and can reverse their effects.
Here's the Narcan.
This is 0.4 milligram?
And this is quite different than the sedatives, alcohol, etc., which also cause drug overdose, where all we can do is wait until the patient metabolizes the drug or eliminates it.
Are you okay? Are you okay? What's your name? What's your name? Dana?
Now, when we're confronted with a patient that may have a drug overdose, what do we look for in the way of physical signs that may point to narcotics? Dr. Laura, what do you use as those physical signs?
Well, the triad of pinpoint pupils, altered sensorium, a coma, and decreased respiration. These can be altered by other problems, and I'm sure you have seen this, Dr. Goldfrank, in the emergency department.
I think that we found that the classic presentation is very rare. Almost invariably, we have a mixed presentation. The patient may very well have dilated pupils. The patient may very well have diffuse findings that are correlated with the other etiologies for overdoses, such as the patient might take in the mixed drug population. So that although we do look for those signs, the necklace sign, various other associated phenomena, a little bit of ice or milk, as I'm sure everyone else will comment on, I think that we get our concern from a number of other issues, such as you've mentioned.
Dr. Smith, are there any clues from the way in which the patient is brought to the Haight-Ashbury Clinic that would tend to suggest a drug overdose?
Well, there are a variety of things that can either help you make the diagnosis or complicate the diagnosis depending on the setting that you're involved in and your rapport with the drug culture. For example, friends that bring the person in, if they stick with the overdose, can give you some idea of what drugs they've been taking. There's a lot of street myth relative to the management of the overdose, including putting ice on the scrotum, injecting the individual with salt, putting them in a bathtub full of ice, injecting them with milk, slapping them in the face, and so that the individual may come in with the trauma associated from street overdose techniques.
Just methadone or what? We know anything
All
else?
we know is methadone was on the street, that's it.
This can help you make the diagnosis, but it can also complicate management in that you have to be sure and clear the airway of blood and broken teeth and some of the things that have happened when the individuals in the drug culture have attempted to resuscitate the individual.
So it sounds like the street therapy may sometimes be worse than the disease.
Right.
Well, we're now confronted with a patient who has an overdose, and he's either stuporous or comatose. He has decreased ventilation and small pupils. We suspect that narcotics may be involved. Dr. Doan, what's the first thing that we do with such a patient?
Well, of course, it's essential to assure an adequate airway, and included in that is the avoidance of aspiration and adequate ventilation, including the administration of oxygen. Even though naloxone will almost uniformly work if it is a narcotic overdose, there are exceptions, which I'm sure the panel will go into later. And you may be mistaken, and of course if you are, then these things are crucial. They're crucial anyway. They're indispensable parts of the treatment of any kind of depressant overdose. So it's very important that these procedures never be deleted in favor of any antidote, really.
So first we think of airway ventilation and oxygenation, and then to confirm our suspicion of the possibility of narcotic overdose, we may use naloxone and Narcan. Dr. Goldfrank, do you find specific responses to Narcan helpful diagnostically?
I think the tremendous advantage of Narcan is that certainly it lacks any agonistic effects as far as we've seen. There really are there's no evidence of the change in pupillary size in terms of a decrease. There's never an evidence of decreased respiratory status, and there really are no psychotomimetic effects. And our assessment really is that if the patient manifests any response after being given Narcan, it's definitive for the presence of a narcotic.
Okay, Narcan's in.
And it's a clear narcotic antagonistic response, and so that we consider that there are no false positive responses. It's a very simple maneuver that anyone who's watching a patient carefully can assess.
So you give some Narcan and you look for arousal, improved ventilation, and perhaps dilation of the pupils as a specific response.
It looks like she's getting some of her own respiration, so why don't you see how she does?
What's your name, dear? Hello?
But Dr. Smith, does this always happen? What might lead to false negative responses to Narcan?
Well, there are a number of things. I think first is inadequate dosage of administration of Narcan intravenously. And very often you have to repeat the dose. This gets complicated when you have a long-acting narcotic like methadone, where you have to repeat the narcotic reversal. Other complicating factors that confuse both diagnosis and treatment are hypoxic brain dysfunction. Also, of course, Narcan is specific only for narcotics. So let's say that the individual has a combined heroin and PCP overdose, a combined heroin and alcohol overdose, a combined heroin and barbiturate overdose. The Narcan will reverse the heroin component of the drug overdose, but not the other drugs, and so you will get only partial reversal. So these would be reasons why you would get false negatives.
So although there are few false positives, if we see a response, we can be sure that narcotics are on board. We have to be particularly careful to give enough of the Narcan if the patient's taken a very large dose of a narcotic. What sort of precautions, Dr. Lauro, do you use in using Narcan?
Well, we do attend to his airway. That's with any comatose patient. We strive to stimulate respiration because your principal problem with the narcotic overdose is related to hypoxia. So we try to bring up their respiration together with oxygen therapy. There is a question in my mind as to how far do you go with Narcan as regards the possibility of precipitating withdrawal? I personally have never seen a case of withdrawal, but again, I use as my index of successful therapy is the elevation of the respiratory rate.
So that we would use Narcan in repetitive doses, one after the other, and in that case, you probably would not precipitate severe withdrawal, and since Narcan's duration of effect is relatively short, even if withdrawal were manifest, it certainly would not last for a very long time.
That's correct.
Well, early on in the diagnostic use of Narcan, we may give it and see a response. The patient may arouse, breathe better, and the question then is, can we use Narcan as a form of therapy? In a patient who has a narcotic overdose and has responded diagnostically, Dr. Smith, can we keep on giving Narcan and keep the patient breathing and awake?
Yes, I think that's very important that you give adequate dosage and that you take into consideration the duration of action of the particular narcotic that they've overdosed with.
It might be important to point out that it works with pentazocine, which isn't true of the other narcotic antagonists.
Right.
And a large dose may be necessary
Oh, yes.
with pentazocine.
In fact, Dr. Doan, would you point out the difference between Narcan and the two older narcotic antagonists in terms of their agonist effect?
Well, that is the main difference, of course. The other two, nailorphine and levodopa, both were just as agonistic as the drugs for which they're intended. So if you gave them to somebody who had another diagnosis, you simply would further their depression.
But that's not true with
And
Narcan.
on the spectrum is different in the regard that we just mentioned, inclusion of pentazocine.
Dr. Goldfrank, Dr. Smith mentioned the importance of giving enough of the drug and giving it frequently. What sort of guidelines do you use in giving Narcan to the patient who does respond when they have a narcotic overdose?
Our position has been to try to find out what the patient might have taken, and depending upon the type of drug the patient has taken and the quantity of the drug the patient has taken, we will respond with repetitive doses at specific time intervals. We don't believe that the narcotic effect, the narcotic antagonist effect of Narcan will last much more than 45 minutes. Some people might say an hour and a half. But our position has been to repeat adequately such that the patient breathes, the blood gases are maintained in an adequate state, and the patient is ventilating appropriately.
So you certainly don't give one shot of Narcan and then walk away from the patient when he wakes up and send him home, because we've certainly seen that error committed, because the Narcan has a shorter duration of action than almost all of the narcotics that the patient is likely to have taken an overdose. Is that right?
Absolutely. Our principle is clearly to save the patient initially, allow for adequate respiration, and protect the patient in the hospital for a reasonable period of time. We would certainly consider that 24 to 48 hours.
Dr. Doan, in using Narcan to treat narcotic overdoses, exactly what routes and doses do you employ?
The drug comes in 1 milliliter ampules containing 0.4 milligrams, and this is the usual adult dose for a known or suspected narcotic overdose. The usual dose for a child is 0.01 milligrams per kilo. That's 10 micrograms per kilo. Again, this is the dose for known or suspected narcotic overdoses.
Dr. Bancella, I have a child. Mother thinks he took Lamodal.
The drug can be given either intramuscularly, subcutaneously, or IV. It is important, though, to realize that if somebody is seriously ill, the important thing is that the drug be gotten into them as early as possible. So that if a vein is not immediately available, and it may be necessary and indeed advisable to go ahead and use another route rather than wait or have them have to wait for the drug. On the other hand, if you can use the intravenous route, it does have the advantage of a more prompt effect and the ability then to titrate the patient. These doses then are repeated if an adequate response is achieved whenever the condition of the patient dictates that more is needed. If an adequate response isn't achieved, my procedure is to repeat these doses every 2 or 3 minutes until I get the response I'm looking for or decide that it's useless to pursue it further.
Okay?
Are you feeling better?
So although you prefer the intravenous route, if you just can't get an IV in for a few minutes, you'll go ahead and give the initial dose at least intramuscularly.
Surely, and this may be very important in the addict, of course, who's used all his veins and doesn't really have a ready route.
Well, what we've learned about narcotic overdose today is it's important to consider this in all the patients who come in with altered mental status, perhaps especially if there's decreased ventilation in small pupils, never forgetting, however, that the presence of other drugs or hypoxic brain dysfunction may alter these classical signs of narcotic overdose. The response to Narcan is specific, and if we see a lightening of the coma, increased ventilation and dilation of the pupils, this will indicate that a narcotic is at least one of the drugs that's present in the drug overdose setting. But there may be other factors which prevent these specific responses from being manifest. For example, hypoxic brain dysfunction and other drugs. Never forget that if patients take large doses of narcotics, it'll be important to use large doses of Narcan. And so the dose that Dr. Doan mentioned of 0.4 milligrams in an adult or 0.01 milligrams per kilogram in a child may have to be repeated many times. And this drug is relatively short-lived, shorter, in fact, than virtually any of the narcotics that the patient likely is to have taken. And therefore, the Narcan doses may have to be repeated as often as every 45 to 90 minutes over a long period, perhaps several days, in treating overdoses with long-acting narcotics such as methadone. Of course, in treating any patient with a drug overdose, we must search for other complicating factors: head trauma, subdurals, infections, especially pneumonia and meningitis. But never forget also that in treating the patient with a narcotic drug overdose, we should employ the same compassion and respect that we find for the bank president who abuses tobacco and alcohol. For that bank president may be our patient tomorrow with a Darvon overdose.